fine. Right, I'll click on that. All right, hi. So good morning, everyone. And that was a brief, quick description by Baljinder. I've actually met some of you, so I may have seen some of you at the interviews or at ARCPs, and some of you may even have sent an email to me about your study leaves. But yeah, so pleased to be here today, and a good morning. We meet in very bizarre times. I hope all of you are well, and you've been looking after yourself. I don't know how many of you, are there about 9 of them here, Bar, today?
No, there's a bit more. I was just making a list. There's usually around 15.
Okay, so now, as Baljinder said, this was sort of not necessarily pulled out last minute, but we, Baljinder's reassured me that you guys have gone through most of your curriculum already, so we just wanted to do something a little bit different. Now, so I decided that it might be a little bit of a challenge, but maybe not such a challenge, because I'm sure all of you are very clever, intelligent, have had lots of exposure to lots of different gynae pathology, and this will be super easy. But it's essentially, so as consultants, we get 2 types of referrals coming to the department. So you get these direct referrals for a request to actually see the patient. So that then goes straight away, and the secretaries arrange a gynae outpatient appointment. And the other type of referral that we get as well is something called the advice and guidance. Now, this is really where the GP is not entirely sure if the patient needs a face-to-face, but they would appreciate a little bit of advice and guidance in terms of next steps and what to do. Sorry, Alexander, I'll see you later, okay? All right? Sorry, guys. We're homeschooling. Just let me close the door again. Right, okay, sorry, where was I? Yes, so we get these referrals for advice and guidance. So the history is variable. Some GPs are fantastic. They give you lots and lots of history, and therefore the quality of your advice, reflects that. But a fair amount of time as well is there isn't a lot of history, and you do end up just asking the patient to come in because you need a lot more information before you can actually give any kind of quality advice. So what I'm going to show you today is actually a selection of advice and guidance that was put into my inbox not very long ago, so a couple of months back in, I think it was sometime in July, August time of last year. And you will see that there is a trend. So there are about 20 of them, I think. So as we go through the different slides, you'll see there's a bit of trend in terms of what comes up regularly. And you get a flavor of that. So I thought what would be useful is we will look at each sort of request. We will go through it together. And I think it might be useful if we have a volunteer who volunteers themselves to actually go through the case. We'll talk about what the issues are in that particular request, and then we'll talk about a response that should go out to the GP. Now, there is no real right or wrong about this. It's supposed to stimulate some discussion. I know it's very difficult when you're online, but what I want is interaction. Okay, no question is a stupid question, and some of these answers I don't know myself, and some of these answers you might know. So it's about learning together as well. And as a bonus, whoever actually volunteers to answer some of these questions can get OSAT or a workplace-based assessment. So I'm going to give you my email at the end of it, and you can send me a little OSAT on it. Does that work? Sounds like a deal?
Yeah, that's fine.
Yeah, that's good. Okay, right. So now I'm going to bring up my slides and slideshow. So you can see that, can't you? Okay, so like I said, we'll read the request, and then we'll pick out what the issues are, and then we can talk about what other information would be beneficial, and then we'll formulate a plan and a response back to the GP. Okay, so now I'm going to actually, oops. Okay, so let me look at, so who's here? So who wants to volunteer? Don't all shout out at the same time. Right, I'm going to pick you guys. I'm going to pick someone. Lydia?
Yep.
Hi, Lydia.
Hi.
So you're in Bucks at the moment. Are you ST1 or ST2?
ST2.
You're ST2. Okay, right. Should we have a go at the first one?
Okay, yeah, that's fine.
Yeah, okay. So I think this is something that you guys no, you haven't. Okay, right. So do you want to have a read? So this is a 47-year-old lady who is suffering from menopausal symptoms of bad flushes, etc. She has factor V Leiden deficiency. Please advise if she can take HRT or not. And if so, how big is the risks and what would you prescribe? Thank you very much.
Oh my God. Okay.
I know. Oh my God. Right, go for it, Lydia. So what are the issues here?
So okay, the information we have, she's 47,
Yeah.
menopausal symptoms, we don't know how long, or
Correct.
just the only symptoms we know are bad flushes.
Yes.
Having any vaginals that
Okay.
symptoms. But obviously vasomotor symptoms. Past medical history, factor V Leiden deficiency.
Yeah.
Which I know very little about. But she wants to take HRT.
Yeah.
Dependent on the risk. So
what do you know about HRT and its risks? What? So you don't know anything about factor V Leiden?
Well, I do a little
Not
bit,
very much.
but not very much.
Okay, but spot on there. You know, those really are the issues, isn't it? So she's 47. She's having some kind of postmenopausal. She's having some kind of menopausal symptoms like hot flushes. It's not bad flushes, hot flushes, and that's about it. And then he gives you a background of that she's got factor V Leiden, which
is
factor V Leiden.
Is it hyper?
Sorry.
Is it
yeah, so it's going to increase her risk of thrombosis, isn't it? That's the concern here. That's what the GP is really concerned about. Now, the other thing about menopause is, you know, she's 47. Do you know what's the average age of menopause in this country?
51.
Yeah, about 51. That's right. So she's a little bit on the younger side, but that's fine. You know, you do get women in their late 40s, well, right all the way up from 40, really, going through the menopause. But it's probably important to also ask whether she's still menstruating, because actually she could be just perimenopausal, isn't it? Because that might influence you on the type of HRT that you would recommend. So do you know anything about starting HRT? So what we're going to do now is we're going to just broaden it a little bit, okay? So not just specific to this particular one, but we're going to just broaden it out a little bit about menopause and HRT, okay? So do you know what are the, you know, when a GP sees a patient and patient's got some symptoms, they're thinking of going on to HRT. Do you know what's the basic principle in terms of the type of HRT that they commence them on? I'm thinking of the two broad ones. Do you know?
So would it be combined or kind of one hormone?
Yeah, so combined HRT contains estrogen and progestogen. and you've also got HRT that's just got estrogen in it, right?
Yeah.
And also there's something called continuous combined HRT, where you give the same dose of estrogen and progestogen daily without a break. And then you've got sequential HRT, okay, where there is a break. There is a monthly bleed. So usually in somebody who's in the perimenopausal phases, so they're still having some irregular periods, or they're still within that 1 year of having had their last period, you tend to put them onto a sequential HRT. And so that just ensures that they have that regular monthly shed, and then they don't have that irregularity. After that 1 year, you can consider putting them onto the continuous combine, okay? So, but you're quite right. You know, a decision whether, you know, you need to decide whether they go on to estrogen, progestogen, or just estrogen only. Do you know when you would give one or the other?
Is it dependent on their medical history and breast cancer and ovarian cancer risk? Is it?
Yeah. So
whether they've had a hysterectomy or not?
Yes, Vinod, is it? Is that Vinod?
Yes.
Yeah, that's right. So if a woman has a uterus, she always has to have combined, okay? She has to have estrogen and progestogen together. Do you, and if she's had a hysterectomy, then no, you can just give her estrogen. Where does this, you know, deviate a little bit? Does anyone know? In terms of someone's had a hysterectomy, where would you think of giving them, in what sort of clinical situation would you think of giving them combined, despite them having had a hysterectomy? Anyone know? Come on. Those of you who work at the JR know this.
Is it to do with endometriosis?
Yes. Who's that? Who said that? Lydia?
Yeah, that was me.
Yep. So yes, that's right. So if somebody's had a hysterectomy and there's pelvic endometriosis that you've noticed when you've taken out their uterus, you may consider putting them onto combined HRT for a couple of years after the hysterectomy. And that's really because estrogen alone may stimulate some of those pelvic deposits, and they could have problems, okay? Could have symptoms. So those are the things that you want to consider. So that's menopause and that's HRT. Now, with regards to factor V Leiden, so you're quite right. Factor V Leiden increases your thrombotic risk. We tend to see that question asked a lot in our obstetric patients, isn't it? They've got background history of either heterogeneous or homozygous factor V Leiden. You know, do they need low molecular weight heparin or not during the course of the pregnancy? So you probably have encountered that in that sort of scenario, okay? So factor V Leiden does increase your thrombotic risk with HRT because we know HRT does increase your thrombotic risk, okay? So as a broad general rule, it's sort of, so there's data for after 50, not so much for under 50. So between the ages of 50 to 59, broadly it doubles it, okay? So that's the way I remember it. I find it easy to remember it that way, okay? So obviously if you've got factor V Leiden, that's going to increase it further from the baseline. Right, so let's move on to, so those are all the factors to consider. And let's go to the next one. Right, so we talked about some of the bits at the top. So now, the thing with oral HRT is that how it increases your thrombotic risk is it essentially affects the extrinsic pathway of the coagulation cascade. And I've just listed for you there all of the changes that occur when you take HRT. Now, there's quite a lot of data and there's quite a lot of evidence to actually show that non-oral route or transdermal HRT doesn't have the same effect. Okay, so that's really interesting to know, isn't it? So therefore, in somebody like this, so once you've sort of, so with this particular lady, if she's got factor V Leiden and she's got personal history of thrombosis, then that's a straight up no HRT for her, okay? But if she hasn't got, if she's never had a thrombotic event, then actually it's less clear whether or not she can have HRT. So then we start looking at other risk factors. So you want to look at things like BMI, does she have a family history? Is she a smoker? You know, is it heterozygous? Is it homozygous? So that needs a little bit more digging, all right? So a little bit more history taking. And if you do decide that actually she's never had a personal history of thrombosis, she's not really got any relevant risk factors that's going to increase her risk of thrombosis, then you might recommend that she go on to sort of transdermal HRT, okay, so in the form of a patch. Let's just assume that she's got, so do you guys know about patches in HRT? Lydia?
I know they exist.
You know it exists. Very good. Well done. So the thing with the estrogen these days is it can be administered via many routes. Okay, so you've got the patch. The patch, you've got estrogen only, or you've got estrogen and progesterone combined. So you've got LS solo,